Hey everyone, my name is Megan Cochran, and I am a fourth-year med student here at UCSD. This presentation is part of my Independent Study Project, or ISP. In creating this learning module, it is my goal to help formalize clinical reasoning instruction during the 401 clerkship. I hope the principles that we will discuss will be helpful while evaluating your patients on the medicine service and in the future. The outline of this presentation will be as follows. We will go over the definition of clinical reasoning, a modern clinical reasoning paradigm, and then conclude by going over three components of clinical reasoning. Let's discuss the definition of clinical reasoning. If you conduct a literature review on clinical reasoning, you'll see that there have been many definitions that have been used. For the purposes of this presentation, however, I would like to use the LCME's definition of clinical reasoning, which is listed in their document, Functions and Structure of a Medical School. This document outlines the standards and elements that all U.S. and Canadian med schools must adhere to achieve and maintain accreditation. Therefore, the definition of clinical reasoning shall be the integration, organization, and interpretation of information gathered as part of medical problem solving.
Now I'd like to go over a more modern paradigm of the clinical reasoning process. So the reason the word modern is in quotes is because this model was actually adopted from an article published in the New England Journal of Medicine back in 2006. Despite being over a decade old, I have seen principles of this article integrated into other medical schools' curricula and exercises, as well as one study on clinical reasoning that was published through the AAMC. I think its appeal is largely that it takes a lot of abstract concepts and translates them into practical and specific recommendations for both clinical educators and students. So now let's review the model itself. You'll notice the model is sequential in nature, and the first two elements, the patient story and data acquisition, are really focused on the gathering of information. This includes elements of the chief complaint, HPI review systems, and the past medical, surgical, social, and family history. It also includes objective findings of the physical exam and diagnostic workup, so things like labs and imaging. This is something that you have all practiced in PBL, POM didactics, your ACA, and perhaps free clinic, Goskis and OSCEs, and of course, other rotations that you have had during the third year. The remaining four elements are more focused on the clinical reasoning process itself and address questions like, what are the key features of this case? And what clinical syndromes does the patient have? And what is the most likely diagnosis? The model also includes global influencers of knowledge, context, and experience, all of which affect the clinical reasoning process at various levels. Finally, please note that you will likely be going through the sequential clinical reasoning process many times during the course of your patient's admission. New information is constantly being discovered, which may or may not change the leading diagnosis or management plan. Okay, now let's go over the three core clinical reasoning concepts one by one. Let's go over the first clinical reasoning concept, problem representation. So problem representation is defined as the 1 to 2 sentence summary that highlights the key features of a patient's case. It's also known as the ID statement and is utilized both in patient notes and oral presentations. We'll go over some example problem statements on the following slides, but for now, to familiarize yourself, it is the typical, Mr. Jones is a 54-year-old Caucasian man who presents with symptoms of ABC with labs or imaging notable for 1, 2, 3, which is concerning for or consistent with XYZ. So the purpose of problem representation is really twofold. First, it orients the team, or whoever you're speaking to facilitate problem solving. Second, it serves as a backbone for clinician communication, which is especially important on the medicine service. A good example of this is calling for consults. If you listen to your resident speak with another service, you'll hear them give the 1 or 2-liner on the phone and then state the reason for the consult. As an MS3, remember that learning how to generate a solid problem representation takes time and practice. It is an ongoing process and is something that we will all continue to work on and develop into our residencies and beyond. Now let's discuss the components of problem representation. At a basic level, a good way to remember the elements are the 3 W's, the who, when, and what. The who is usually listed first and consists of the patient's name, age, sex, other demographics, as well as pertinent past medical history and risk factors. The when is the temporal pattern, and the what is the clinical syndrome, which often integrates key symptoms, exam findings, and diagnostic data. If we put this all together, we get the following general format. First, we list the patient's name and age. Occasionally, you'll see physicians put in an ethnicity or race, but this doesn't really appear to be universal. We then state if the patient is a man or a woman. Here at UCSD, you'll hear a lot of presentations and see a lot of notes saying male or female. While this is acceptable, it is actually preferable to say man or woman. As a side note, if you're ever submitting an abstract for a case report or doing an away rotation on the East Coast, make sure to say man or woman for the patient's sex. Next comes the pertinent past medical history. Sometimes you'll hear physicians mention if the patient has had a recent admission, especially if it's relevant to the reason they're being admitted now, or if the patient had a major medical event, like a STEMI. Next, we'll comment on the patient's presentation, which again includes the chief complainer symptoms, and then go on to say the clinical syndrome. Finally, we conclude with the reason for admission, which often uses statements such as consistent with, concerning for, and admitted for. So here's a pretty comprehensive yet concise and organized example for an MS3. Mr. Jones is a 54-year-old Caucasian man with a past medical history of hypertension, diabetes, HFrEF with an EF of 24%, and tobacco abuse, who presents with subacute dyspnea on exertion and peripheral edema, with workup notable for an elevated BNP and pulmonary edema on chest X-ray, overall concerning for acute decompensated heart failure. Another important point that I would like to make on this slide is that usually, as you get more advanced in your training, you'll start to exclude certain things from your problem representation. For example, your attending might just say that the patient is admitted for acute decompensated heart failure. They can exclude things like the chest X-ray and lab findings because these are diagnostic data that are implied by the clinical syndrome itself. Now I'd like to go over a couple of points that really helps make for a quality ID statement. First, try to use precise medical language, specifically semantic qualifiers. The definition of a semantic qualifier is a paired opposing descriptor that compares and contrasts diagnostic considerations. And the example I've listed here is polyarticular, as opposed to saying something like a lot of joints, or simply listing all of the joints that are involved. In addition, when we say polyarticular, this naturally implies the fact that this is not monoarticular, which would be expected in something like gout or septic arthritis. Other common examples are phrases like unilateral versus bilateral, focal versus multifocal versus diffuse, mild versus moderate versus severe, and acute versus insidious onset. The second point that I'd like to make is really try to avoid irrelevant or extraneous information. Try not to list every single active medical problem for the past medical history. This can be exhausting and actually distracting, which can take away from the main issues. Third, try to prioritize pertinent information. A good example would be listing the cardiac risk factors of diabetes, hypertension, and tobacco use in a patient who presents with chest pain, as opposed to highlighting something like eczema or depression. On this slide, we can compare problem representation in a novice versus an expert. So if you look at the novice on the left, we see that the ID statement is a bit lengthier. The format seems okay. The novice adheres to the general framework that we had outlined earlier. However, they then delve into some descriptions that can be consolidated into semantic qualifiers. So in this example, right knee pain becomes monoarticular in the expert problem representation. Starting suddenly last night becomes acute. In the setting of previously self-resolving episodes becomes recurrent gout. The expert then takes things one step further by demonstrating the appropriate interpretation of the joint fluid aspiration versus the novice who simply lists the results one by one. So it's actually interesting to note There have been studies demonstrating that an increased use of semantic qualifiers has been linked to stronger clinical reasoning abilities. Next, I'd like to offer some practical advice and some things that I picked up during my third year of med school. So number one, try as best you can to avoid copying forwarding your intern or resident or other physician's notes. I would really encourage you all to write your own ID statement from scratch and then compare it to others. The reason for this is that you'll learn so much more if you write your own ID statement and put it together piece by piece, as opposed to just simply copying and pasting someone else's thought process. Number two, remember that everyone has their own style. So some people have a lot longer and more detailed problem representation, especially if you're on the medicine service, while others have a much shorter and to the point ID statement, like the surgical specialties. Number three, you should reassess and update the ID statement at least once a day. Things can quickly change on the inpatient setting, especially as you get new labs or imaging results back. Also, new problems can occur. So for example, if your patient was initially admitted for pneumonia, but then developed sepsis, this would now be the number one most acute problem, and this should be reflected by your ID statement. Finally, it's important to note that oftentimes what we write down for the ID statement in a patient's note is not necessarily what's articulated during oral presentations. This is especially true as the days go by and we as a team become more familiar with the patient. So sometimes you'll hear the attending ask for a very simple, short one-liner just to orient the team. Let's move on to discuss diagnostic schema, which is the second component of our clinical reasoning concepts. So diagnostic schema are cognitive tools that allow for a systematic approach to a given clinical problem. Now there are many kinds of schema, and we'll discuss them over the next couple of slides. So as an MS3, you may not have a framework readily available when you go see a patient for the first time, and that's okay. So I remember one of the first patients that I saw when I was on the inpatient service at Scripps Green, and I was a third year. And the patient that we were going to go see was admitted for syncope. And my intern said something like, oh, this is, bread and butter medicine. And then he told me that I had 10 minutes to look up the patient on the computer, and then we were going to the ED. I remember frantically going through my Step Up to Medicine textbook, and luckily there was a really good section on syncope, that broke it down into the etiologies of neurogenic versus cardiogenic, etc. So my point is, if you don't have a schema readily available, that's okay. You're a third year med student, and this is the time where you look things up. Let's talk about some commonly used diagnostic schema. So the first one I have listed here is an organ system approach, and this is particularly useful for generating a very broad differential diagnosis. The example I have listed is chest pain. So essentially, you would go through the cardiovascular system, the pulmonary system, the GI system, and so on, and then list different causes of chest pain within those categories. Again, this is a very broad approach and gives a big picture kind of mentality. The second schema is vitamin DEC, so vascular, infectious, traumatic, and so on. As UCSD students, I feel like that we are particularly strong in this schema since it is really emphasized during our MBB courses. The example I have listed is monoarticular arthritis. The third schema utilizes a physiological construct. So good examples of this schema are the AKIs, so differentiating between pre versus intrinsic versus post-renal, and then the anemias, so dividing them up into macrocytic versus normocytic versus microcytic. The fourth schema is anatomical. So this is a consideration of different ways that organs or structures can cause a disease. The example I have listed is epigastric pain. So we can look at esophageal versus gastric or duodenal versus pancreatic versus cardiac causes of epigastric pain. Finally, on this slide, I have listed as causation-based. So this is a consideration of ways that a specific problem can occur. A good example is hypoalbuminemia. So the liver could not be making enough, the gut could be not absorbing enough, or we could be losing protein into the stool or urine. Now on to more diagnostic schema. So first, let's talk about situation-specific schema. This is usually seen when we have a clinical problem that has a very established method of evaluation, such as the renal tubular acidosis, which can be approached as proximal versus distal versus hypoaldo versus combined. What makes this situation specific is that we don't see this approach used for any other clinical problem other than the RTAs. Next, I'd like to talk about combination schema, and this is a really important concept. A lot of the schema that I mentioned previously can be used synergistically, in sequence, or within one another, so to speak. So the first example I have listed is peripheral edema. You'll notice that it utilizes categories from both organ systems and a vitamin deck approach simultaneously. Hence, this is an example of synergistic combination schema. For the second example, again, we usually divide AKI from a physiological perspective into the pre versus intrinsic versus post-renal categories. If we then look at intrinsic disease, we can divide it into an anatomic approach. So this is an example of a sequence combination schema, where we first use a physiological approach and then use an anatomic approach. Now, we'll talk about the really important concept of buckets. This can be well illustrated by looking at the elevated anion gap metabolic acidoses. So the classic mnemonic that we all know as med students is MEDPILES. However, I personally feel that the buckets approach is much more useful since it emphasizes the pathophysiological processes of gap acidosis, as opposed to simply memorizing a list of causes. So some buckets that we can use for elevated AGMA include lactic acidosis, ketoacidosis, renal failure, and toxic ingestions. You can also note that each of these categories is further broken down into their own differential diagnoses. So for example, lactic acidosis can be approached as type A versus type B, while ketoacidosis can be approached as diabetes versus alcoholism versus starvation. The last category I have listed here is other. So, of course, there are some approaches that just don't fit into any of the above categories, and this is okay. The example I have listed here is dementia, where we can look at irreversible and reversible causes. All right, so the final component of clinical reasoning that I'd like to talk about are illness scripts, which are organized summaries of disease knowledge. The main takeaway from illness scripts is realizing that there are certain features that help define a disease, as well as features that rule out other diseases. And we'll go over some examples in the following slide. It is also important to know that illness scripts are less about memorizing every single fact possible, but actually more about how we store information. When we look at how experts utilize illness scripts, we see that they do so in a compare and contrast format. And a good example is something like rheumatoid arthritis, which is a symmetric polyarticular arthritis that's more common in females, versus gout, which is an acute monoarticular arthritis that is usually seen in men. So as medical students, we are in the very early phases of translating basic knowledge into illness scripts. On this slide, I have an example of a very simple illness script for gout. On the left, you can see the main components, which include risk factors, pathophysiology, symptoms, the physical exam, workup, and treatment. So defining features are features that are typical of a disease or a diagnosis. So gout is usually a monoarticular arthritis. So monoarticular would be considered a defining feature of gout. Compare this with a discriminating feature, which are descriptors that help distinguish diagnoses from one another. If a patient with arthritis does not have fevers or systemic symptoms, this suggests that it is not septic arthritis, hence making this a discriminating feature. Finally, there are certain things that are pathognomonic or highly suggestive for a specific diagnosis. So monosodium urate crystals with a negative birefringence under polarized light are considered pathognomonic for gout. Now we have made it to the end of the presentation, and we'll conclude by talking briefly about the assessment. So use all of the information presented earlier to summarize the case, and then list your leading diagnosis and why. So remember to always provide supporting and refuting evidence, so this can be any element including the history, the exam, the labs, etc. If several diagnoses are still possible, you should talk about them in order from most to least likely, and again, provide supporting and refuting evidence. A final consideration you might have is highlighting diagnoses that you can't miss.
Thank you for listening to this presentation. Please feel free to email me, Megan Cochran, or my ISP committee at the emails listed below for any questions, comments, or concerns.